Over the years, the most important thing that we have learned is to, as we were discussing, as Srini was saying, to get a very stable access. Now, one of the pathogenetic mechanisms of a dural fistula is ischemia. So invariably, in dural fistulas, you will find a lot of stenosis at the ostia of the artery. So over the last 5 to 6 years, we have started using a 4 French diagnostic catheter as a guide. Because a 5 French guiding catheter or a 6 French guiding catheter, somehow in a narrow ostia, it does not go inside. So what we do is, in the beginning stage itself, we try at least with a 4 French diagnostic, like you see here, and you will see during the embolization, once the microcatheter is in place, and once you have the microcatheter a bit distal, you pull the sim down so that it enters into the intercostal artery. So this is one of the maneuvers that we have found useful in embolizing dural fistulas. Now let's see how this case went. Somebody was asking about the angioanatomical correlation. So basically, you are at the intercostal artery here. This is the somatic branch, or this is the intercostal artery proper. And these are the branches which are going towards the neural axis. So what you are basically seeing is you are seeing these tiny branches that are ramifying on the dural sleeve of the exiting nerve root. And this is the target. In fact, the fistula point is this. This entire L-shaped area starting from here and going up till here, this is the fistula point. And the moment you see the dimension of the vessel changing, these are the veins. You can do a lateral view, and then you can make sure that these veins are posteriorly located. You have to do a lateral view. You should always do it because you want to make sure where exactly the position of this fistula is. And then subsequently, we do a cone beam CT reconstruction, and that also shows us the position of the fistula. Now, once the fistula has been identified, the most important thing to do is to spend time on the catheterization. So now you can see, because we had a relatively smaller caliber catheter, we have wedged this inside into the intercostal artery. And then now this is a regular Marathon 1.5. With the Marathon 1.5, this is a Mirage 007 wire. With the Mirage 007, you have taken the relevant branch that you wanted to catheterize. And now, very slowly, very gently, you are trying to, you pull your wire and you push your microcatheter so that you have a kind of a push-pull between the microcatheter and the wire, so that the inertia which is stored in the microcatheter actually propels it forward. This is a flow-guided microcatheter. So you cannot expect it to behave the way in which a non-flow-guided microcatheter behaves. What you are pushing at the groin is not getting transmitted to the tip. So basically what you have to do is you have to load the entire system. You load the entire system with inertia on the microcatheter, take your wire more distal, and then when you keep on pushing and pulling and torquing the wire, your catheter will generally go in front. So point number 1, you have to have a deep position in the intercostal artery, usually with a 4 French diagnostic catheter. The catheter initially for injection was in this configuration. Now you can see the catheter is in this configuration. With that, we are inside the intercostal artery. Use a SIM2. Don't use a SIM1. Use a SIM2 with a larger curve so that you get extra backup from the opposite wall of the aorta. It compresses the catheter into the vessel. And then, once you are in position, once you have reached the position that you wanted to reach, the rest of it is pretty straightforward, pretty simple. You do an injection and you make sure that you are in the fistula. This is an AP view. In an AP view, you also have to remember that the nerve roots, they are not just horizontal, they are pointing backwards. So you have to appropriately go to the lateral angulation. So this was the AP view, and now you change yourself to a relatively lateral angulation. In the lateral angulation, you see your entire fistula site much better, much better. You can see that this is your entire target that you want to fill. You are seeing a small radiculomeningeal twig which is coming down, that is of no concern. And then subsequently, you do the glue injection. I hope this is the glue injection. No. This is what we are testing with contrast. We are testing exactly where we are and how exactly the contrast is behaving. And then this should be the glue injection. The aim of the injection is to fill up these up till maybe here. More than that is not necessary. If you can go up till there, it's fine, but usually we try and stay at the bottom of this fistula. So now the glue should come. Yeah, that is the glue. The glue comes, the glue goes, and the glue goes up to the wall of the fistula, and the entire thing is knocked off. So that is your glue cast. You can see that you got a nice cast going all the way along the dural sleeve. If you do a cone beam CT of this after the procedure, you will find that the entire the contrast mixture is trapped on the wall of the dural sleeve. The same thing happens either in a lower intercostal, cervical intercostal, vertebral artery fistula. Wherever you have, once you finish the procedure, you will see that the contrast is on the sleeve around the artery. So this was one case. Then I wanted to show one more case. There will be certain situations. For example, Srini showed you a case in which we had some glue going up. It went up into the spinal venous plexus. So the worry there is that is draining normal spinal cord also. So you don't want that area to get filled up with glue, because if there's a venous thrombosis, you will clear the fistula, but you will have a venous infarct higher up. Similarly, in certain cases, like for example, in this case, this was a dural fistula in a 65-year-old lady. And this was a case in which the fistula is only this much, where I'm showing. Only this much is the fistula. In fact, in this case, someone was discussing, you can see the multi-level intersegmental anastomosis as well. But the fistula point is only this much. With this much of fistula, you can see the amount of spinal venous congestion on the 3D. And you can also see this huge sac. This was the one which had bled, actually. The patient had come to you because of a bleed. Bleed and compressive myelopathy kind of situation. So whenever you are trying to deal with these fistulas, you have to be double sure that your embolic material does not enter this sac. Because the moment you close the fistula, the sac will thrombose and go away. But if you fill this sac with a large amount of embolic material, the mass effect will remain. So the compressive myelopathy will not improve. So when you are dealing with these cases, you have a very, very short area that you have to disconnect. So this was the AP view, this was the slight oblique view. We went ahead, the same glue preparation. Again, the catheterization, spend time. Here we used, I think this was probably a headhunter only. This was a headhunter, it has come out, but it's okay because the tortuosity is not that much. We are going with a 1.5 marathon and we are going with a Mirage wire. Even though this is a radiculomeningeal artery, we want to reach somewhere there at that area so that the glue penetration can be controlled much better and it will go only antegrade. So at the end of this, again, pushing, pulling, loading the system. The moment you load the system and pull the wire out, the catheter will go forward. So catheter goes forward. You just need these extra 2 millimeters or 2-3 millimeters of a movement to occur. You just want it to go somewhere up till that level. Once it goes up to that level, we again do a cone beam CT. We exactly see where is the fistula, what is the fistula point. And now this is going to be the glue injection on a 3D roadmap. That is the glue being injected, and you can see that the glue is coming from the radicular artery, from the radiculomeningeal artery, the radiculodural artery, and then this vertical component is the place where you exactly need the glue to go, because that is on the wall of the dura. This is the nerve root sleeve, and that vertical position is the wall. It's the wall of the dural artery, the dura covering of the spinal cord. So the moment this is done, you do a repeat 3D and you demonstrate that you have disconnected the fistula, and at the same time, your glue has only gone up to the entry point of this particular stage. So the red thing is glue, and the rest of it is the fistula. Over the next few weeks, this entire thing will collapse, and the compressive myelopathy will go off. What is again important to see, these are cone beam CT images of the dural fistula before embolization. You have the posterior radiculomeningeal artery, which is going and forming the fistula on the dorsal surface of the dural covering. And then subsequently, this is the connecting link. This is the extradural to intradural venous connection, and that is the venous pouch. This is the pedicle which is going and supplying the dural fistula. And once you finish the procedure, you have to demonstrate that even your embolic material is sitting exactly in the same place. Let me just, this is the DSA, this is the angiogram, and this is a native run without any contrast. This shows you that the disconnection has happened. This shows you that the disconnection has happened exactly at the interface of the radiculomeningeal artery and the dural system. This was the pre-procedure injection. This is the post-procedure injection. You can see multiple intersegmental anastomosis. You can see a radicular artery, intersegmental anastomosis going back into the aorta, refluxing into the aorta, and then you can see these multiple vessels, but there is no fistula. For such a huge fistula, the glue cast is only this much. So you basically need 0.2 or 0.3 ml of embolic material, which is precisely deposited exactly in the point. Pre-embolization, post-embolization, upper level, not the level which was supplying the fistula. That has to be done. This was the presentation of the patient. The presentation was definitely she had some spinal cord congestion, but the most important thing was this venous pouch. Immediately post-embolization, you can see that all the vessels are gone from the posterior part, and you can see that this is started to thrombose already. Most important, rapid venous thrombosis has to be avoided. You have to make sure that you give the patient at least a week of anticoagulation in these situations, and avoid venous infarct, avoid dehydration, avoid hypotension. All those important things need to be taken care of. So I think that is what I wanted to show. So if there are any questions on these two cases. Yeah, Amit, Polo. You can't. You can't. But why do you want an undershoot? Because, I mean, what are you trying to see in an undershoot? You already have your roadmap. You already have a microcatheter in. So subsequent, all the runs will be from the microcatheter. Kaushik?
That gives us an advantage because the shape is also like that, that doesn't shift off. Any idea on that 5 French?
We basically reshape all these catheters according to the case. Okay. We reshape the 4 French. We fine tune the shape according to the anatomy.
Okay. And the second question is, sir, based on whatever, I'm not able to get that reference right, whatever limited experiences we have had. We are always talking about spinal dural AVF being symptomatic more because of the venous congestion.
Yes.
So when we embolize and sometimes we don't get these results, they always say that the venous congestion takes some more time to disappear.
Yes.
So do we routinely recommend laminectomy for these patients?
No.
Can we go surgically and try to open those up? Because
you have not caused so much of cord swelling that there is no space in the spinal canal. There is space. So why would you want to do a laminectomy?
I think from a literature, sir, I'm not able to recollect.
Maybe. See, because like what I'm showing here, this MR is probably, I think pointer has given up. Anyway, that MR which I showed, that is just 24 hours post-procedure. So 24 hours post-procedure, all your dilated veins have disappeared. The venous engorgement takes 2 to 3 weeks to disappear. And if you have not got necessary, USB-C se charge karna. If you have not gotten satisfactory results from embolization, it means that there is some other pedicle which is still filling it.
Just a theoretical question, sir. Supposing we make this as a hybrid procedure, because we do not know how much of the nidus or fistula tract we are always, because we always say these cases needs to be followed up for recruitment. So if we are theoretically going in and embolizing this with a glue or an embolic material, that becomes radio opaque. and it becomes easy for us to hit the surgery, and probably we'll be able to achieve a good result with a hybrid. Meaning, I'm just asking this, sir, because we have done this like 3-4 cases, and some of the patients have done really well. I do not know whether it is.
I mean, whichever technique you use to disconnect the fistula,
yes,
it
sir.
will work. Whichever technique you use. So, I mean, I don't have the capability of doing surgery. So whatever I do has to be done on the table. So probably that made us spend more time
on that,
and not give up and convert it to an open procedure immediately. See, the situation also decides how your program develops.
If that, then the follow-up question is, sir, how much of patients just with endovascular you have clinical improvements, sir?
Almost all.
Wow.
Almost all. Because, see, the improvement will be incomplete if the fistula, if the venous congestion has been there for 2 years or 3 years. The motor comes back first, the posterior column sensations come back second, and the sphincter may or may not come back. That is what we have seen in our 8 to 10 years of observation. Every patient, I mean, not a case in which the cord has become thin like a string. That is gone. That's a gone case. There we don't embolize also. Because we tell them that the chances of improvement are very less. But if the cord is as big as you see, and it's swollen a bit because of venous hypertension, that still means that your funiculi are there. If you want to be very careful, you do a SSCP before that. You do a somatosensory evoked potential and see if it is conducting at least. Even if it's not conducting, and even if the patient has been symptomatic for 3 to 6 months, and the cord is thick, we go ahead and we do it. Motor, in fact, within the week of discharge, the foot drop and all those things will disappear. And then it will progress proximally.
Thank you, sir.
And having your approach of having a hybrid technique for all spinal dural AV fistula doesn't make much sense here. I mean, you can do an angiogram. If you think you're not confident of embolizing it, better leave it to the surgeon to take it down.
Immediately, yeah.
And to localize it, there are different techniques. As I told you, some people inject little glue and stuff. The standard techniques used in the West is, what they do is, after they localize the spinal fistula, they would just dorsally localize it and put a injectable coil in that region, around close to the pedicle, because the nerve root is just below the pedicle. Close to the pedicle, they would put in the muscle an injectable coil. They would just inject it so it's easily picked up by the C-arm during surgery.
Paritosh? Okay, fine, anyway.
Sir, you said you shape the SIMS or the guiding according to the case. Would you share some tips on how to do this?
Steam shape, simple. Put a mandrel inside, shape it according to your want, give it steam, give it maybe 1 minute of steam.
Which mandrel?
Any mandrel.
Any wire?
Yeah, any solid thing which can retain the shape. Sometimes just with your hand, just with a gauze piece, if you can bend it and if you can hold it in steam, if you have that much of purchase, you don't need to put anything inside also. No. Cobra is a good catheter for diagnostics, but it's a big, bulky catheter. So if you want to really, and it will always keep on pointing down. So the moment you, and it's very stiff. So the moment you try to wedge it, it will come out.
So you can do this with the Cobra and then over the wire exchange with
Yeah, why do you want to exchange? I mean, you can hook it again. Microphone.
Yeah, as you said that there are often stenosis in the ostia. So what we found out, coming to your question, like we use a C1 to initially hook it and then put a exchange length wire, take out the C1, and a vertebral glide of 4 French will actually dive much deeper into the intercostal and they will hold their position really well. So that actually also helps because we don't use the same too much, but the glide really goes in deep inside and holds its position fantastically. So that is one thing that you can do.
The patient, I mean, practically after the angiogram, practically you have to make the patient prone. You're going to put this injectable coil on the muscle, close to the pedicle, just to localize the level, you know.
that will remain there.
Yeah, it will remain there. It's an, I mean, it's an implant, no? It doesn't matter. I mean, On the muscle. Back.
In all cases, fixing or endorsing is required, or you can just do it with everyone?
You can do it. You can do it, but supposing you have only one shot at it, and you have a young child, and you don't want to spend too much time, so better you use all the techniques so that one shot it's done. Any more questions? Low molecular weight heparin, LMWH.
7 days.
7 days. Once a day. The DVT prophylaxis dose. Just give that much so that the blood is just a bit thin. It does not solidify. Keep the hematocrit down below 32 so that you don't have any dehydration or anything. That's all. 7 days, you just stop it. No. Methylprednisolone, जिस दिन ASA में जाएगा उस दिन डालेंगे. Everything depends on the amount of venous engorgement. If the veins were very small and tiny, nothing to be done. But if you have a huge venous segment which is ectatic, which is slow flow, as it is, spinal system is a slow flow system, that can thrombose. And basically, thrombosis is always progressive. You just need a small thrombus to start, and then that's it. It's a cascade. So better to avoid this and better not to do anything. After the procedure, anyway, for a couple of hours, your heparin will have some effect, whatever you have used in your flush or whatever. But the moment we shift the patient to ICU, we give one dose.
You mean that when there is a long segment of venous congestion, there is no venous outlet at all?
Venous outlet is there, but those veins are so dilated that in the lack of a fistula, they will not drain as much as they were draining before. Because they were using the fistula flow to clear themselves. Now there is no fistula, but the huge vein is there with a column of blood inside it. So that should not thrombus. That is a static column. That should not thrombus. Just cut it at the groin. And the question was a stuck microcatheter. Just cut it at the groin. Nothing happens. It has to be a new microcatheter. And a reused microcatheter, you will have thrombus. So there you'll have to use antiplatelet or whatever. That means you have not found the pedicle. You have to keep on searching.
How many times?
Happens. But we don't give up till we find it. In fact, now for localizing the fistula, we don't use DSA. We use first pass MR angiography. My technicians, they are so good that my MR technicians, they do what we call as a first pass MR angiography. The moment you inject GADO, within 10 seconds of it, they do an ultra fast sequence. So I will show you, we don't use DSA for localizing fistulas anymore. We do that on MR. We take the patient up for a curative procedure. But supposing you don't see something on MR, then we take the patient up for. So there you have to start studying from thyrocervical, localized fistulas based on MR.
Before embolization, you must be doing an entire
In the same sitting. So the advantage of that is, it is a single procedure, it is under GA, so your patient's gut has been prepared, so a lot of advantages. You have a jumping patient on the table for a spinal DSA, it's very painful. For the simple reason that after 10-15 minutes of lying still on his back supine without moving, the patient also starts becoming uncomfortable. Spinal DSA you cannot finish off in 10-15 minutes, unless you are very lucky. That is straight away you went into the pedicle, one shot above, one shot below. That never happens. So that's why we localize based on MR, and then we go ahead for a single stage procedure. MR angio. Contrast MR angio. Glue in the anti-spinal artery. Yes, I will show that case after the break. नहीं एंटी स्पाइनल में गया नहीं सर, उससे सल्को कमर्शियल में गया। नहीं वैसा नहीं हुआ अभी तक मेरे साथ, वैसा नहीं हुआ। ग्लू काम ही नहीं करेगा, कुछ काम नहीं करेगा। ग्लू विल ओक्लूड दैट वेसल विद इन 5 to 10 seconds, 5 to 10 seconds, उसके बाद कुछ काम नहीं करेगा, नथिंग विल वर्क। वो मरीज खुद ही ठीक हो गया होगा कोलैटरल सप्लाई से, और वो यूरोकाइनेस को बेनिफिट मिल गया। Any other questions? No other questions?